Hi, this is John Kanelopoulos from Athens, Greece, and clinical professor of ophthalmology at NYU Medical School in New York City, New York. My pleasure to describe to you some of the basic principles of our LASIK technique. This is the X500 excimer laser. We did the beta testing for this device. I think it's serial number 003 back in 2009. It's next to the X500. Next to the X500 rather is the FS200 femtosecond laser. And we can see that the swiveling bed is now positioned under the FS200, and we're doing the fine adjustments to treat the left eye. You can see here the steps where the actual software of the FS200 excimer laser is adjusted for flap depth, flap diameter, the hinge angle, and several parameters of the chimney. It's a little vent port that's created within the hinge, and this is a brilliant idea by the Wavelight technician. This is the patient interface. We can see that comes calibrated from the factory, but the FS200 recalibrates each given patient interface every time it's placed in the laser apparatus. So it has a hyper-reflective surface, and then the laser calculates the distance of the PI for patient interface, validates its accuracy, and gives us the go-ahead. So thus the parameters are absolutely pristine. We've reported in the past in the peer-reviewed literature several of the advantages with this femtosecond laser and its extreme accuracy and flap creation. Here we're showing that I'm going to adjust the head position in order to have the cornea level as horizontal as possible. We saw here that I was able to drop the headrest a little bit and bring in the head in a more comfortable position for this particular patient, but also more horizontal. So thus the femtosecond laser PI will come down in a vertical fashion. This is very important. I know some of these may sound redundant for experienced LASIK surgeons, but for the beginning surgeon, these are very important points. We will use a Tegaderm as a patch on the left eye. We'll use half of it to draw the upper eyelashes and then another half for the lower eyelashes in a way to drape the lashes away. We've prepped the eyes with betadine swab stick before to rub the eyelashes and leave some of the betadine solution in the cul-de-sac, and of course that after a drop of moxifloxacin. And here's the aspirating speculum. We will not use aspiration during the femtosecond laser flap creation. And we're coming here, this is really great filming by our friend Paolo from Milan, and we're seeing some great images now. We're looking at the surgeon's view and how the ring is placed slightly superior. You see the crescent, the scleral crescent inferior to our picture is more prominent. I'm rocking the PI slightly across the eye to have it adhere to the conjunctiva. Engage suction on the suction ring that I had placed on the patient's cornea. Now I'm with my joystick dropping the PI that applanates the cornea, and we can see a side view of this. Here we're seeing the reticule of the laser, and we can move it around within this very broad area of applanation. And really the FS200 has the broader applanation than the other femtosecond laser. And we're seeing here in real time the actual lamellar cut, which takes under 6 seconds, and now the vertical cut that separates the flap, and we're all done. So this is real time as far as the femtosecond laser flap creation and how it's performed with the FS200 femtosecond laser. One important point that I omitted to mention, we're seeing how I'm engaging the suction ring in the left eye. Sometimes in order to avoid having the nose of the patient come very near the FS200 apparatus, we'll tilt the patient's head away from that. So in this case, we would have tilted the patient's head towards the right and thus give a better field for the left eye, and vice versa for the right eye. Tilt the head towards the left and give a better field, uninterrupted field for the femtosecond laser. Here we're seeing the flap creation on the left eye. See how fast this is. You can see the chimney that vents the air that's created by the million of femtosecond laser created bubbles. We are using the 110 microns low tap to congratulate our patient. And now what's magic with this platform is that the bed swivels automatically. We don't have to move the patient under the EX500 excimer laser. We're seeing here the excimer laser settings. The laser will engage the eye. It has cyclorotation within its tracker that recognizes iris architecture and limbal architecture. Here I'm using a disposable irrigating spatula as the tool to lift the flap, and thus any instrument that's used within the flap is disposable, single use, one for each eye. I'm tucking the flap onto itself in order to avoid having the flap exposed and potentially have particles from the laser room attached to the backside of the flap. And here we can see the excimer laser, 500 hertz, 500 spots per second. Really a significant ablation performed under 10 seconds. And we've evolved and published repeatedly how we have used customized treatments with this excimer laser topography guided treatments named Contura by the company. We've added our own nomogram adjustment named TMR, topography modified refraction. In this particular patient with high myopia, we are doing prophylactic cornea cross-linking by placing riboflavin under the flap for a minute, then repositioning the flap in place. I'm using suspension steroid in order to delineate the flap margins, a Johnston applanator to iron out the potential kinks, micro kinks that the flap may have in the area under the flap that has been ablated. And here we're using the Avitro KXL1 device to boost the corneal biomechanics by using 60 seconds of 30 milliwatts per centimeter square fluence. This, of course, not available in the US. This is available outside the US since 2013. And we're seeing how this device adds just 2 minutes in the procedure. We reported extensively how this recovers some of the corneal biomechanics lost in the LASIK procedure, not to be used as a means to perform LASIK in keratoconus or form fruus keratoconus eyes, but in eyes of younger patients that were treating high myopia, we've showed evidence that it may add to long-term stability and also the way the epithelial remodels afterwards, especially in high myopias. So we're going to see the same procedure in the left eye from a side view here, and I really like this take because it's very important for the beginning surgeon to see how we line up the patient. Everything has to be orthogonal. Patients tend to tilt their head sometimes, so we want shoulders and neck to be in orthogonal angles. And the laser has this crosshair red lights that help you orient the cheekbones, the forehead, and the shoulders of the patient. We're seeing here how I'm lifting the flap from the hinge side down, releasing the very fine adhesions that remain after the femtosecond laser delineation. I'm tucking the flap onto itself in order to avoid having any particles from laser room land on the backside of the flap. Here we're seeing the laser in action. One important thing back in the microkeratome days is that usually beginning surgeons tend to push things down and bring everything of the cornea level down to the speculum level. It's very important. You can see here how far up the cornea level is from the speculum level. By the way, the speculum is an aspirating speculum, and in the femtosecond laser at the point of beginning, when we wash the surface and then irrigation under the flap, here's the riboflavin placed carefully onto the exposed stroma and not onto the flap, because once we reposition the flap, we want the UV light to go through the flap that does not contain riboflavin and reach the soaked underlying stroma. And we will, in this way, increase the biomechanical strength of the cornea, which by LASIK has been reduced by at least 20%. So here we're going to replace the flap in position, rinse away the redundant riboflavin solution, and finish the procedure as if we were not going to do adjunct cornea cross-linking. Avijo calls this LASIK Extra. Here's the suspension steroid that helps us delineate the gutter and thus justify the correct position of the flap. The Johnston applanator, rocking it across the cornea in order to remove any residual fluid and iron into the central cornea onto the stromal divot created by the extramural ablation, confirming the position with more suspension. And we're finishing here the case with the KXL1 device mentioned before, 30 milliwatts per centimeter square fluence for just 60 seconds. This delivers under 2 joules of total energy. The device has a joystick that can help us center it on the patient's cornea, and the red crosshairs center the UV beam on the z-axis. We can see here a close-up, very magnificent filming by our friend Paolo. Grazie Paolo. And treatment with the UV device is over. We will, you can see it here from the surgeon's view, we'll remove the KXL1 device and then rinse the surface, place a bandage contact lens, which we invariably do for the last 10 years in all our LASIK patients. It increases comfort for the first night. We remove it the first day after surgery, and also reduces friction between the eyelid and the patient's surface of the flap. So we're removing very careful the speculum. This is a moment where if the patient squeezes or if the speculum bumps the flap, you may have flap movement. So we're all done. We can see the headrest going back into place. We'll have the patient come up. We'll start watching. Congratulate her for a great job done. And again, we're seeing how carefully we remove the speculum to avoid any contact of the speculum with the cornea surface, removing the Tegaderm drapes. Carefully dab the surface, and we're all done. So this is our LASIK technique. We're using moxifloxacin and dexamethasone, Perforte in the US, 4 times a day, at least for a week. No showering, avoiding washing the eyelids. We only do that in the office. Here we're seeing a different plane of the same procedure. John Canelopoulos signing out. Hope you found this interesting. Thanks so much.